Bishop.
Our gracious Heavenly Father, let's thank you for this day and this life-giving rain, and be with each and every person at this table that they might do your work for the Cherokee people. Look over each and every soldier overseas and their families here at home, and guide and protect them and bring them home safely. In Jesus' name we pray. Amen.
Amen. And next we have roll call. Please acknowledge that you are here.
Fred Scott, Janelle Fulbright, Bill Anglin, Bill John Baker,
Here.
Jack Baker,
Here.
Carly Buzzard,
Here.
Julia Coates,
Here.
Joe Crittenden,
Here.
Jody Fishinghawk,
Here.
Meredith Fraley,
Here.
Don Garvin, China Glory Georgia, Curtis Snell, Chris Cope,
Here.
David Thornton, Kara Calhoun.
Honey.
We do have a quorum.
Next, approval of the May 12th, 2009 regular session minutes.
Second.
The first and second, all those in favor?
Aye.
Any opposed, same sign. Motion carries. Next, we have two reports, and Mr. George, you seem to be up first. You're the first contestant.
Thanks, sir. Morning.
More service units.
You have my report in your packet. A couple of highlights. We are really pushing hard for a new OBGYN chief. Dr. Hilliard left a couple months ago. That has been advertised. I'm not sure how many applicants we've received, but we're pushing hard for that. And the other place we're really pushing hard is for LPNs. That goes hand in hand with the chronic care team that was started June 1st. Things are going well, but the first thing that jumped out at us is we didn't have enough support for the docs. So we're trying to recruit and get in some more LPNs to handle the patients a little more efficiently with the docs.
Mr. Chair.
Yes, please.
Thank you. It just dawned on me. I don't know. I mean, we have our own, obviously, our own healthcare system with our own needs. But if there's a match that's closer in Claremore, do we send folks over, even though it's an IHS facility? We've got recruits that may not be a match for us, but
We just talked about that.
okay. The other thing is do you talk to other services, because we have.
We did.
Thank you.
Councilman Buzzard.
Yes, George, I see that you've been awarded your stimulus funding for the picking machine and then for the new roof there at Claremore.
Yes, sir.
And then how does, I know this is IHS, but what's the policy on advertising for roof repair, roof bids? Is it?
It'll have to go out to bids. What we'll do is we'll have to get together a scope of work and request for proposal and send it down to the area, and they'll send it out for bids.
Do they send it out for, I'm going to say taro, but that's not the word. Does Minorities get the bid on that?
Yes.
They do, so it will be advertised.
Absolutely.
Okay. And the other thing, just a comment, is I'm just amazed, or I'm glad that the health department is actually getting those stimulus funds, but we seem to be having trouble with DOI here at the nation of getting those funds out. So I don't know what the problem is. I think Vicki Hamby will probably answer that in executive finance, but I just want to make the committee members aware of that health has got their stimulus funding and we're still waiting on DOI for money. I don't know what the problem is, but thank you for the answer.
You bet.
Thank you.
Councilman Hoskin.
George, could you, just to clear up any confusion that I have and others might have about contract health out of Claremore, could you provide a sample denial letter that clearly shows where folks are supposed to appeal, and then any procedures that you all have that you can share internally as to how those appeals are handled? Specifically, to what extent does the Oklahoma City office make determinations, and to what extent Claremore makes determinations? And then finally, just confirm that people who appeal and are denied are actually getting a response that their appeal is denied. Because I often get feedback that, hey, I sent an appeal and I didn't hear anything. I've actually sent appeals on behalf of some constituents, and I've checked with them and they say, no, I didn't receive anything. Now, they could be missing something, but I just wondered if you could just kind of lay out for me the procedures and the sample dismissal letter, and that might help me help them.
Okay. I can get you, I can bring a sample denial letter with me next time.
Okay.
Now, if you have a constituent that did not receive a denial letter, if you will have them call me, they should receive a denial letter for every time they are denied or deferred.
Okay. And then I guess the follow-up is, if they appeal, are they then told that their appeal's been denied?
They should receive a letter likewise for that. And if they don't, please, within a reasonable amount of time, let's just say 30 days, have them call me, and I will make sure that they get that letter right away.
And the sample letter you'll bring will show whether they're supposed to send their appeal into Claremore or Oklahoma City, because it seems like the ones I've seen indicate that they should go to Oklahoma City.
Okay.
But I think there's even been some confusion, at least on my end, about that.
Okay.
Okay, thank you. Thank you, Mr. Chairman.
Please go ahead.
On the stimulus package there, we have, area office has been advised the $500,000 for the CT machine. We start paperwork Monday on that to get that sent out for bid. We have been advised part of the roof money. The roof was estimated at $1.7 million, and we've already been advised $900,000 down to the area level. We've been told that the rest is on its way. So we'll start paperwork on getting that out for bids here pretty quick. We're like Hastings and the rest of your clinics. Our new charts are going up, and reactivations are up. We're still up 570 last month on new charts and reactivations. Our collections, for the first time I think in history, I've been told, Claremore almost hit $1 million last month, which is a milestone for Claremore. I look for us to hit that and then set our sights onto the $2 million mark after that. And with Melissa and I have already been talking about different ways that we can enhance our collections. And I appreciate her help in steering me in the right direction. Our CHS activities, we sent in 3 more chef cases, and we've actually had 10 of those funded up to this date.
Anything else?
On the chef cases, has everyone that you've turned in been approved?
No, we still have 6 or 7 waiting to be for a decision.
And tell me again, when does it turn into a chef case? What is the number?
25,000.
Okay.
Any more questions? Thank you.
Thank you.
Next we have Ms. Gower, Recreation Health Services.
Good morning.
Morning.
You received my report, and if you have any questions about it, I'll try to answer that. I did just want to give a quick update on stimulus. We were approved for a roof and a digital climate control system for Hastings. We haven't actually received the funds yet, but we should be getting those shortly. Medical equipment, we got 2 fundoscopic optometry cameras and allowance for 3 new ambulances. That's it for stimulus for IHS. And the money's already been advised to area, and so we should be getting that in our compact very soon. And that's all I have. If you have questions about the report, I'll be glad to try to answer
Councilor
them.
Fishing Hall.
How many is in high school, actually?
I believe it's 25.
Thank you.
Councilor Jordan, I believe, and then Councilor Dodger.
Will that, Melissa, will that put us on track to meet our goal?
We're still on track.
Okay. So if we meet our goal, then we won't have to provide them funding.
That's correct.
Any longer, okay.
Council Buzzard.
Melissa, and you may have told us before, but apparently I didn't hear it. We don't know, what is the status or what are we doing in Hastings as far as Ed McLemore go? You know, Ed was the CEO up there for years and the Cherokee speaker and everybody, we all liked Ed, but haven't seen him, and who's running the operations there in Hastings is kind of what I like.
Okay, Dr. Chuck Grimm is the acting CEO at Hastings. And Ed is on a leave of absence. He requested a leave of absence to go to the Creek Nation to help them with their health system.
Councilor Stowe.
Yes, I've got two questions. And one, saw an AP news article the other day that was discussing in healthcare, and I assume it was a nationwide distribution and so forth. One of my questions is, do you see a growing concern or a growing momentum behind the national effort to focus congressional people on Indian health care? And if so, what are we doing as an organization to try to support that? I know we're always talking and so forth, but seeing that, it just seems like there's a little bit of a momentum there building, and that's one question.
Okay.
And then if you can answer that real quick,
Okay.
I got a follow-up.
Well, a couple of things. One is there's kind of two things going on. One is that there is some momentum building for funding issues, and we have been a recipient of that. Most recently in the 2009 Omnibus Appropriations Bill, $15 million got put in contract support cost. Oklahoma area got 3.8, Cherokee Nation got 3.4 of that. So that's contract support cost dollars that we've been in arrears for years. There's lots of momentum toward improving the funding rate for that. In the FY10 President's budget, they've put in $115 million for contract support costs, which would mean a lot of money for us because it would fund the contract support costs that we didn't get for Hastings Hospital. Just last week, Melanie Knight and I went to Phoenix, Arizona to a national contract support cost meeting to develop a strategy toward trying to keep that in the budget and advancing that. So we have a national work group that's working on that policy issue. They also have been trying to put some more money in contract health, and we may see some fruits out of that. So there are some efforts pushing toward that. On the other side, with national health care reform, there are some efforts to hurt Indian Health Service. And on that front, we also have been working with congressionals and committee staff to try to make sure that Indian country is heard and has a voice on national health care reform. From Cherokee Nation, we have developed a policy paper on national health care reform. I've met with the Committee on Indian Affairs and provided that. They actually then came down and had a visit with us, and I think Councilor Hoskins came to one of our meetings that we had on that and talked to them about the issues that we had in that. In addition to that, they then asked us if we would coordinate a meeting for Oklahoma area to get tribes in Oklahoma to have a voice on it, and we did that, and that was held on June the 5th. So we're pushing forward and moving through the Washington office and then just through health on trying to make sure that the Indian voice is heard in healthcare reform and we're not hurt. But there are some efforts to try to do some of that in Indian healthcare.
The other question was kind of follow up on Councilor Hopkins' request, is that in matters regarding the contract health, what's the exchange like between the patient and the personnel at the facilities, is there a particular process that's followed, or is that vary from time to time depending on situation? I was just wondering if there's some type of a policy, or if there's a packet that the patient receives, because much like Councilor Hoskins, that's probably my number one issue is, contract health in accordance. We know that not all people's medical bills can be paid for, on a certain priority. We understand that. But I think just the confusion aspect of it is what is a little bit intrigues me to wonder what our processes are like at either one or both facilities. And I think my situation, and might be his, is a little unique because we have a couple of options, and people have different things that they do, so that kind of increases the opportunity for confusion. So do we have a procedure that we can relate to, or a packet that is generated? I know there's a lot of counseling that goes on, but I'm just curious as to how that can...
We do have, I've got a couple comments. One is we do have that. And I wanted to say when Councilor Hoskins asked about, not receiving things, and George and I actually talked about this a little bit this morning. One of the biggest reasons people don't receive the information is because they don't have their current address in the system. And, we ask for updates every time they come in, but repeatedly, if we sent out a blanket thing to all of our patients, there would be a 25 to 30% return for bad address. And we ask over and over, is your address or anything changed? And no, but it's a constant battle to ensure that the addresses in our system are the most current addresses, and that's one of the biggest reasons that people don't receive written mail information, is because, not always, but that's one of the biggest reasons, is because of address problems. So if there's one thing I could encourage you, is to be sure to encourage the people to make sure that their information in the system, registration information, is most current. And secondly, I'm thinking that since George is bringing back next month some copies of papers and forms and stuff, that maybe it might be helpful at next month's meeting for us to actually have an educational session, just a 15-minute thing or something on contract health services, and have our respective directors, maybe even, or George can do it. But for me, it'd be helpful to have Brett to come with me and help just give up and say, this is our process and this is how it works, and this is what would be helpful if you could do, and those kinds of things. And I'd be glad to do that if you would like to do that.
I think that would be beneficial to me personally. Thank you.
If I may interject, I've got a lot of people waiting, but I want to interject before we get off on another topic, because I want to go with that. A couple of things that, and I know that we talked about this, and I know that you work on this, but two of the things that I get a lot of phone calls on, and this one I specifically know that we've addressed, I still get phone calls, and whether someone at the clinic is actually saying we're out of money, or if that's what the patient heard. The reality is that we're not funded. We're just not funded by the federal government. There is not enough money. It's not that we're out. There just isn't enough money for contract health. But what that leads to is, at least on my phone calls and the emails I get from constituents, is that when, whether someone actually said we're out of money or they heard we're out of money, the perception is the same, and that leads into all of these casino discussions and what are you doing with the money. It just becomes, so I know that may be something that just have to stay on top of, because that's the last thing that people need to be told. The next thing is that I wanted to touch on was, when you come back, that may be something to address. I know you said you were going to bring some things back, but one of the confusions that I constantly get from constituents is that they assume if they received a referral that it's paid for. And I don't know if the patient is not, it gets confusing for patients. We all know that. I don't know if that's what they're hearing or that's what was actually said, but, and I know that. We've addressed that too. But that's just one of the questions that consistently comes up is somehow because I'm one of these people, it doesn't matter what was said, the perception is the reality. And they believe if I receive a referral, then it's paid for, and then all of a sudden they get a bill. So you may address that next time when you bring this stuff, because I do know that that's the perception. So, but I know when you've addressed that, and I know ever since I've been on the council, that's a constant thing that you fight. So I know you are working on it, but I do appreciate that. And I just want to interject too that, and I know Councilor Watson and I have been to D.C. with Health and Human Services, and Councilor Soap, I saw that article too last week, and Cherokee Nation Health Services just won an award, pretty big award actually, the only tribe that received it, and I can tell you, compared to some of this reservation stuff, we are way ahead of the game. So I know it's a constant battle, but boy, I know some of those, we sit at the table in D.C. with some of those folks from out west, it's a whole nother issue out there, so we should be thankful for that. Councilor, Madam Speaker Fraley, you are actually next.
I'm actually going to pay you a compliment.
Thank you.
No, at AMO Salina, the lab over there, they're just an excellent, well-organized lab.
Good.
They get the
They're
reports
out of
out at
room.
time.
They're out of room in lab.
Yes, they are.
We're trying to figure out a way to get them
And
a
I'm
little
sure
better.
that the dental clinic will be just as well organized.
I'm sure it will be.
But no,
I'm
they
sure
do
it will
a
be.
very
We're
good
excited to
job.
get that going.
And when I can't get anyone on the phone, I go to the lab, and they find whomever I need to talk to.
So that's good. That's good. Thank you very
I'll
much.
put in telephone.
No, that's good.
Councilor
That's
Hobbs.
great.
You mentioned that Indian healthcare being hurt in the context of health. Is it your sense that it's being hurt just as an inadvertent byproduct of expanding healthcare?
Well,
or that there's moves underway to take this up, seize this opportunity to?
I think both. I think as a byproduct, we need to make sure that the Indian Health Service system stays intact and is not hurt as a byproduct of healthcare reform. That's one issue. And then secondly, there are some congressional efforts by the Senate to totally reform the Indian Health Service system, and it would not be beneficial for the Cherokee people.
Okay, thank you, Mr. Chairman.
Councilor Baker.
Recent complaint,
Okay.
opportunity.
Opportunity?
Yeah,
Okay.
recent opportunity.
Okay.
I'm starting to get phone calls that people need medication. We've got it on a formulary, but they can't get it until they get a primary care physician. And they're telling me 9 months to a year is what they're being told before they can get a primary care physician. And these are, of course, medications that are expensive that they can't get on their own, that yada, 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 but it's in our formulary. But the walk-in doc can't give it to them. They've got to have a primary care, and so we're telling them suffer for 9 months or a year.
Okay.
Is there any solution to that?
Well, there is. I had one patient that I was working on with that, and we asked them to go to walk-in to see the walk-in doctor, which is where if you don't have a primary care provider at Hastings, and we're working on changing some of these things, but currently that's where you go for your primary care until we get a family practice clinic there. And so this one particular patient did that, and it was not fruit for them for a number of reasons that we've talked to the patient about. But we've taken care of that and fixed it. So that's not an
And then I didn't
issue.
want to call on, but
Yeah, I'm sure it is. So I've taken care of that one, and we sat down and talked about how we can prevent that from happening in the future. So until we get some changes, if one comes up, just, let us know, and we'll address it. But I think we've got that fixed.
okay. That's it from here.
Councilor Coates.
I wanted to go back to the questions just about the database. I had heard from Secretary Knight that they have been working on the database within the nation itself to get a good address so that they're cross-checking between registration, the Phoenix, and Human Services in particular to try and get the most current address that we may have for individuals and to have that information shared around. And I was just wondering if the Health Services Department, or group is involved in that.
I have
in
no
that data
idea.
sharing. Okay.
I don't know that. I'll find out.
Councilor Buzzer.
Yes, Melissa, this is, I want to go back to registration. These are just comments, I guess. Not trying to tell you how to run your business or anything like that, but it seems to me like you made the statement a while ago that bad addresses on notifying people. Well, we have clerks there that are supposed to ask that question, and if they say the same, most people are going to say, yeah, same. Why don't they read the address and say, is this your address? The other thing is, maybe we need to have, like Chief Smith, I guess initiated one time as a mystery shopper, to go around and see that these things are actually being happened, or actually being done. That way we would know, and the good thing that Councilor Coates talked about the database, that's something that, could really work for all of it. But anyway, those are just suggestions. I know a lot of people, I've been into the public stuff, and you ask them, is everything the same? They'll say yes, because they don't want to go through the problem of telling you the changes. But if we have receptionists there that reads that stuff and says, is this your address, then we may be more accurate. But those are just suggestions. We can see some things that you probably already know about, that we don't know that you know it, so that's where you don't want to bring it up.
Thank you.
Okay. Thanks, Chairman.
Councilor Crittenden.
Thank you, Mr. Chairman. I just a comment, Melissa. Mr. Becker brought up a while ago about the formulary. Recently I was contacted, and you and I talked, and I think it's probably one and the same. Appreciate the help that you gave this person, and encouraged to know that we're trying to work on this primary doc situation. Because 9 months is, it's way too long. But thank you for that.
You're welcome.
Thank you, sir.
Anything else? We talked about, I just wanted to, Councilor Buzzer, that was his request, and I did request that the third party be broken out by clinic like it used to be. And Melissa, if you want to take like 30 seconds and brag on your award,
I'll let you do it.
you go right ahead.
Brag on yourself, come on. Well, tell me so I can brag on it.
No, I want Brad to do it.
I don't know quite as much detail as you do, but I do know we're the only tribe to win the award. It was basically our approach to medical care. It was more of we are more concerned about the quality and the I don't know what word I'm looking for, but it wasn't. What am I looking for? It was basically our approach, and I gathered from the article it had something to do with kind of how we started trying to set those pods up, and
It
I'm going to
is.
force you to tell us, because it was basically we won the award because of our approach.
We did. As you all know, we've been participating in what started out being called the Chronic Care Initiative by the Director of IHS and the Institutes for Healthcare Improvement, which is a worldwide healthcare improvement organization. They do work worldwide on improving healthcare systems and processes. And then it's now called IPC, or Innovations in Planned Care. And we were one of the initial 14 sites in the first demonstration program. And we were always ranked first in the 14. That's what we strive to do. Somebody told me this morning we won second, and the Telequal Daily Press something, and they wanted us to do a press release on it. And I said, no, we don't do press releases on winning second in Telequal. We want to be first. When we get first, we'll do a press release. So, and then Innovations in Planned Care 2 has come out, and we are in that one also, and have been basically what they do is they measure your outcomes, your quality indicators, based on the way you deliver care. And because of delivering care in a more comprehensive, for a slang term which is called pods, we set up pods where we have a physician, a mid-level or 2 physicians, an RN case manager, and an LPN for each physician. And we impanel patients, so they have a primary care provider, and we send a letter to all the patients, and they actually get to pick who they want as their primary care provider, and that's who they see every time they come in. They have a relationship with them, with the case manager even, where they can call the case manager if they're just having problems, and they can decide whether they need to get in or not. But our quality indicators have improved more than anyone else. And we're very high on, which is an indicator of the quality of care that you provide. So it's not just, we provide a great quantity of care also, but it's not just about quantity of care, it's about the quality that we provide. And so in addition to that, our accreditation body, which was a Joint Commission accrediting organization for hospital organizations, DNV is a new accrediting organization. They're not new, they've been around for years and years, but they are a worldwide accrediting organization, and they don't just do it in the United States, they accredit health systems across the world. And we just recently were awarded, which I think is what you're specifically talking about, we were just recently awarded accredited by the DNV system accrediting organization. So we're the first tribal hospital or health system in the United States that has ever achieved that. And we're the first hospital system in Oklahoma that's achieved it. So we're very excited. We think that it basically puts us on a whole new level for the delivery of health care. Thank you.
We are now to old business, and there's none pending. We're to new business, and I understand that these 3 are discussion only. The first is comparative effectiveness research. Councilor Con Watts, you have the next 3.
Thank you, Mr. Chair. So in front of you, they handed out the letter that'll be sent. Some other tribes, because they're constructed with different constitutions and the business committee type model of government business, they actually would pass resolutions, and we just have a different method of doing business. So this is the letter that Chief Smith has signed and sent forward to the new Secretary of Health and Human Services. And by the way, I think that these next 3 items are day-to-day examples of how much work and the detailed work that goes behind our healthcare, not just the delivery of that system, but the legislative work that we do as our healthcare staff does, both locally but at the federal level. So right now, with the American Recovery and Reinvestment Act, or that's what's happening on the Hill, and everybody talks about, and your GM bailouts, and we've got healthcare reform and all these things going on, and then how that money is going to be thrown into healthcare, that there is the Federal Coordinating Council, or FCC, which is looking at comparative effectiveness research. So several of you have asked about healthcare reform and how it might impact the tribe. Well, this is one, from what I understand, and I'm by no means an expert, this is a critical aspect of how they will reform healthcare going forward is using how they define comparative effectiveness research and then where they apply that money and what they do with the outcomes of comparative effectiveness research, whatever that comes to mean. So they're not, right now on the Federal Coordinating Council, Indian Health Service does not have a seat at the table, which is problematic. So this letter from us as the Cherokee Nation, as well as my work on the Health and Human Services, Office of Minority Health, American Indian Alaska Native Health Research Advisory Council, which I also will call ATRAC. That is, I would serve as co-chair on that, and so our consultation as that formal committee of elected officials in Indian country has also asked that Indian Health Service be included on the Federal Coordinating Council. And all of us are asking for opportunity for direct tribal consultation because that has not occurred either. And there's problems if they're going to look at whether, does comparative effectiveness research mean that they are going to look at only fiscal outcomes? Did we efficiently use our money in a healthcare format? And that might determine how you get a doctor or you fund a clinic. Or is it about clinical outcomes? And did we care for the patient and get the right results with respect to their health care? Does it deal with chronic issues? Does it provide for traditional medicines, maybe alternative medicines, which are different from traditional medicines, but those methods of health care might be more, we might want to include those. There's a lot of questions, so if this is something that you're interested in, I would really like to hear from you because I represent our Oklahoma City area on the ATRAC. As well as I'm trying to work with our health staff to make sure that we submit formal consultation in a timely manner with the federal deadlines, and this is our letter. Thank you.
Councilman Bronson?
What types of entities are on this FCC now? IHS does not have a seat at it. What type of entities are on there?
Like, the reason I knew about it was the Office of Minority Health or Deputy Assistant Secretary Garth Graham is who is basically assigned to the ATRAC committee. So he sits on it on behalf of the Office of Minority Health. And then you would have like Medicare, Medicaid, and then you would have CMS. You have all these different agencies within healthcare, or different aspects of the agencies within HHS, NIH, which is National Institutes of Health. You have all those folks. I think veterans are on there, but we're not, right? I believe. I believe.
The VA, because it's a.
Yeah. So if you can Google for Federal Coordinating Council, and you can actually see a list of the individuals with their pictures and bios that are seated on the Federal Coordinating Council. And they've had listening sessions. They've had 2 now, or maybe even a 3rd. I watched the first one. It's 3 hours long. It's archived on the internet, on their website, and so. That's also available to you. It's very telling. During the first session, it was pretty much all paid lobbyists, primarily for healthcare and pharmaceutical industries. No tribes were present and provided testimony. They're given 3 minutes for verbal testimony, and then you're limited to 1,500 words, I believe, for your submission, your written submission.
It's truly shocking, Mr. Chairman, that pharmaceutical and health industry lobbyists would be. But seriously, has there been an explanation as to why we've been excluded?
My understanding was we weren't there to yell about it, I think, and so now I haven't gotten a good explanation, but we're just now at the table in the last month or 2.
Well, I think part of the reason is that Indian Health Service is at the director level, and they're not at the secretary level within the executive branch. And so what they'll typically do is someone from DHHS will be on, but then they won't go down into the agency level. And so, as you're well aware, Indian Health is a lot of the times not selected for those types of things just because of the level they're at, which is one of the efforts of Indian country legislatively, is to raise the level of Indian Health Service from a director level to an assistant secretary level.
Thank you, Mr. Chairman.
Any more? Councilor Watts, or do you have any more?
Yeah, that's all. I just want to make people aware, and if they're interested, I really would like additional input because right now, besides some of the conversations I've had with you, we're the only two elected officials I know engaged on the issue, and I think that's problematic. So if you don't mind, I'll go on to the next one. So the National Children's Service, or Children's Study, we talked briefly about it last meeting. And this is the letter that's being submitted because, again, I think Indian Country's representation is lacking in the National Children's Study. You can read the letter for yourself. The one thing that I would, if you're interested in what we're going to do on genetics, DNA, blood tissue sampling, how we as a community choose to deal with that and respond, I think that there's discussion being had now at the with our health staff. And I understand we might potentially even look at public meetings. I'm not sure how you were going to proceed. They're still studying and considering what they want to do as a plan. So if you want to have input on this, how we determine interacting with outside researchers as well as maybe inside research that we do ourselves with respect to genetics and blood tissue sampling and those things. We need to start having that conversation now because it will take us as much as a year or two to formulate our policy and determine as a community, as a tribe, what we want to do. And this study speaks to that.
We have a policy because we have an institutional review board, an IRB, within our health system. And so we have a policy already on all of that, of how we operate that. But one thing Dr. Graham has talked about is that at some point we kind of like to engage at a broader level about what Cherokees think about their kids participating in studies and tissue samples and those kinds of things. We have a cultural committee on our IRB that develops all the culturally relevant policies. So we have that component, but at some point, probably not in the near future, but at some point we may want to get some broader input into that process.
Any discussion on this? You still have the floor, Councilor Watts.
That's it, and I go on to the next one. So the next is National Institutes of Health. They lack a tribal consultation policy. I find that this is of grave concern because of the significant amount of the budget they receive from the HHS budget. And HHS has a large budget, portion of the federal budget anyway, and then NIH, or National Institute of Health, has a significant amount. Where the rubber hits the road on where it's a big problem is not only the lack of research or maybe what research is being done, if any, in Indian Country, but they also allow government box checkers. So if there's a fellowship we know that we would like our own people trained to do this kind of research. It would be much better in our community if we had tribal people that were already familiar, understood our issues, doing health research. Maybe we would resolve things quicker, for example, because they could get to the root of the problem being Indian themselves. So when I go to HHS tribal budget consultations, I've been the past 2 years in D.C., and that's also tribal policy and budget consultations, we find that there's no Indian presence in NIH, really, or very little. And then they allow huge fellowships where people get paid anywhere from $20,000 to $40,000 a year to go to school to do research, as well as get their schooling paid for through these fellowships. But they're allowing every Cherokee princess to claim whatever, and they have no concept of what tribal enrollment and tribal identity is, and that's a loss of opportunity to Indian Country. And one of the reasons is they lack tribal budget consultation. So this letter is in that, and there's other tribes sending resolutions as well, and we're sending this letter, and it's to open the door to talk to NIH about developing a tribal budget consultation. And I just think that you guys should be more informed on these issues because there needs to be several of us engaged and involved in these issues and not just a few because they're all going to end up being part of national health care reform and all these other issues. And they've been going on before national health care reform. And so I'm looking for partners on the council that could assist in these different areas. Thank you.
Well, I think in general, the executive branch or the federal government, whether it's whatever branch, probably, it's really the root is about treating Native Americans as a race versus the political status. And, you know, they just don't have, so they treat us as any other race, which is self-identification. And that becomes a problem when they're representing in a study that they've done that, you know, these things are about Native Americans, and you say, well, how do you know they were about Native Americans? And when you
Because they said so.
when you get down to the root of it, you know, the same problem with the census is that everything is self-identification.
Right.
So it's really about the legality of being treated as a race versus a political status.
Councilor Waltz or Melissa, do you feel like at this time that you have any kind of a champion, maybe too strong a word, but on the Senate side, do you feel like there's anybody that is even remotely listening?
Oh, yes.
Okay.
I know our staff is.
We have champions in the Senate side, yes.
Okay. Any more questions? This is a pretty big issue, I think. At least when I was in D.C., I think the council would be kind of shocked to realize what groups and entities are accessing untold amounts of money by self-identification as, yes, I'm Indian. And it's not only research studies, it's not only research grants, it's college scholarships, it's employment. It is absolutely rampant, and I completely agree with your assessment. You get this self-identification, and it's because it's viewed more as a political entity than it is a race. And that's always a tricky subject, but it's getting out of hand up there. It really is, in my personal opinion. But I appreciate that. If there's no more, Councilor Butler.
Just a comment, and some of this I'm familiar with because we dealt with tribal consultation with DOI for years and years, and I know it's a process that you go through, and it's difficult to get these letters for an executive order out of the president to even do this sometimes. So I realize that the frustration that you get from going through that. I'm not quite familiar with this stuff on this, but I know on the DOI side, it was a fight for years and years to even get those into the executive orders for consultation with tribes, even on DOI stuff. So, yeah, this is important stuff. I appreciate the update on it. Thank you.
Anything else? If not, we're to announcements. Are there any announcements? Seems there are no announcements. I would entertain a motion to adjourn. First and second, all those in favor say aye.
Aye.
And any opposed, same sign. Motion is carried. We are adjourned.